Hello everyone. Today we'll be discussing about abruptio placenta. This is Dr. Suraj. Let us start our journey of placenta abruption or abruptio placenta. Abruptio placenta is also known as accidental hemorrhage. Yeah. So this is the separation of the placenta is happening even before the baby gets delivered. So normally what happens, the baby delivered, after which after certain periods the placenta gets delivered. But here the placenta is detached from the maternal attachment, okay, even before the baby baby gets out of the mother's womb. That is my abruptio placenta. Okay, now coming into what are the risk factors of abruptio placenta. This is going to be a very crisp and very crisp discussion. We'll be not going here and there. We'll be just focusing our discussion on management of the abruptio placenta. Risk factor, please remember, most important risk factor is previous history. So if there is previous history of abruption, do consider it. And either the pregnancy induced hypertension or hypertension in pregnancy. These are two different terms. Pregnancy induced hypertension is basically a placental pathology where after 20 weeks a normotensive female, when gets pregnant, during the antenatal period, during that period only, after 20 weeks, because of the placental pathology, hypertension developed, and that is true in a non-hypertensive female. That is called PIH, and that will be might complicate with eclampsia. That thing will come in a separate video. So if that is associated, abruption chance increased. Even with age and parity, the chance of abruption will increase. Very important predictor is the abdominal trauma. So please remember, once they have asked what are the predictors of abruptio placenta, one is uterine contraction. If there is premature uterine contraction, that can lead to separation of the placenta from the desidio basilis and can lead to abruptio. And any history of abdominal trauma will make you suspect placental abruption. Understood? Very good. So these are the risk factors. Do not forget about smoking and cocaine abuse. Let us discuss very important thing here. Once they have asked this question is a page grading. So what is page grading in placental abruption? Okay guys, placental abruption में page grading क्या है? Okay, so let us understand this thing. So it has 4 grading. Okay, number 1, number 2, number 3, and there is number 0. Number 0 is diagnosed after the placenta gets delivered. You will see that there is retroplacental clot there. You will see there is retroplacental clot. Okay, and you see here there is retroplacental clot. This is the placenta here, and you can see there is a retroplacental clot, and this retroplacental clot is diagnosed only when the placenta gets delivered. Okay, that is grade 0 according to the page classification or page grading system rather. Okay, next coming into grade 1, grade 2 and grade 3. Please remember, in all this grading system, you will be having pain plus bleeding. You will be having pain plus bleeding. Okay, but the difference is in grade 1 you will be having normal fetal heart sound. In grade 2 you will be having fetal distress, and fetus will be dead in grade 3. So fetus will be dead. Okay, so that is page classification or page grading system. Just remember, in each of the grading 1, 2, 3 mein you will be having pain and bleeding. Please remember, this pain and bleeding is a very much important feature of placental abruption. Okay, you have to differentiate it from placenta previa also. You will not see there is so much pain is not associated in placenta previa, because here trauma is there and separation of the placenta from the maternal side, leading to huge release of tissue thromboplasm. And because of this release of tissue thromboplasm, that can cause severe pain. Now coming into the grading system हो गया, तो अभी types we have revealed types, we have concealed type and mixed type. Okay, once I have made this video and uploaded, but because of the voice problem I have to reconsider it, so I am going first this time. Mixed is most common. You will get mixed type of placental abruption most common. So what is mixed here? Mixed means you will be having revealed plus concealed. Okay, revealed means, see guys, this is placenta and the detachment or separation of the placenta started from the margin. Okay, the separation of the placenta, this is the placenta, so this separation of the placenta started from this margin. So whatever is bleeding there, this bleeding is coming through the internal os and coming out, which you can parvaginally see or assess. Concealed variety means this is the placenta is there and you see this placenta gets detached or separated from the maternal attachment side or deciduovasalis. So what happening is the blood which is accumulated in the behind the placenta, so that is the retroplacenta. So this blood is accumulated and this blood is forming the clot. I have shown the image already, that is retroplacental clot, and this retroplacental clot is forming, so you will be having no bleeding, which is obvious. That's why it is called concealed variety, and most commonly both are actually same combined. Let us discuss few clinical picture so that you can understand. So in placenta previa you won't get that much of pain. I already told you why you won't get that much of pain. So pain and bleeding, very much important features you will be seeing. And as there is release of tissue thromboplasm, so that is actually causing the uterus so much rigid and it is fixed that you are neither able to palpate the fetal parts nor able to assess the fetal heart sounds. This is so very important because each of them can be assessed in placenta previa. Okay, so I have just told you everything: risk factor, page grading, types, what is accidental hemorrhage, definition, predictors, and this thing. Here I want to mention one thing, that in concealed variety what happens, because of the accumulation of the blood just beneath the placenta, yes, you will be having no bleeding, but when you see the uterus from outside, it will look like this, that the whole of the uterus is like bruised. Okay, it is like kind of bruise is there from the outside of the uterus. You will see this is known as cuvellaris uterus. Okay, this is known as cuvellaris uterus, which is also known by uteroplacental apoplexy. Okay, just want to show you this image, just see. Now coming into the management portion, that is very important here. Let us concentrate on that. We'll be managing this situation. So whenever a patient is coming with placenta previa, okay, another thing I want to mention here, please remember that placenta previa and abruptio placenta, okay, these two are there. Abruptio placenta is very it's a medical emergency, as well as sometime you need to do emergency LSCS. Okay, why? Because this is the fetus, so this is the loss of blood happening from the fetus, so it is a fetal blood loss. But in placenta previa, guys, it's a maternal blood loss. So obviously this is important we have to be much more vigilant enough to manage this condition, abruptio placenta. So whenever placental abruption case is there, first thing I know that this is fetal blood loss is happening, but at the same time you have to assess the maternal status, that whatever resuscitation measure I have to take, I have to resuscitate the mother. Okay, so maternal resuscitation has to be done because ultimately you have to control it. Now, after resuscitating the mother, you have to assess the bleeding, whether it's a mild bleeding happening or moderate to severe bleeding happening. Mild bleeding means your maternal hemodynamic will be stable. Moderate to severe means the vitals will be unstable, associated. There might be associated shock is there in mother, can be there is oliguria or achia will be there. Mother can develop DIC also, or even there may be non-reassurance of fetal heart rate or fetus distress. So if anything is there, I have to do immediate C-section. If the moderate to severe bleeding is there, or the mother is in shock, DIC, or the fetus is in distress, in each and every condition I have to go for immediate C-section. Coming into this side, mild bleeding. So whenever there is mild bleeding, guys, you have to look for the gestational age. So look for the gestational age. There is a catch here, because when the gestational age is less than 34, I can go for expectant management. So expectant management can be done if the gestational age is less than 34 weeks. Now what are you going to do in this expectant management? Please remember, here you have to admit the mother first. You are going to admit the mother. Now as you see, this is less than 34, that means the fetal lungs are immature. So lungs are immature. So as the fetal lungs are immature, you have to give steroid. So you are going to give injection corticosteroids. Okay, so you have to give injection corticosteroid. Let me discuss a few points regarding injection corticosteroid, because questions are asked from here. You can give betamethasone, or you can give dexamethasone or betamethasone. The dose you have to remember. Okay, please remember, betamethasone is given, these two are given IM injection, both are IM injection, but the dose is different. In betamethasone, what is the dose here? Yes, the dose is 12 milligram. So you have to give 12 milligram dose, 2 injection of 12 milligram, 12 hours apart. 24 hours apart. Okay, so 12 mg 2 injection, 24 hours apart. Now this is important. Why? This is different in case of Dexa, because you are going to give 4 injection of each 6 milligram 12 hours apart. That means if you give betamethasone, then you give 1 injection of 12 mg. So 12 mg IM you give, then after 24 hours, you again repeat 12 mg. But if you are giving dexamethasone, then you give 6 mg. After 12 hours, again repeat 6 mg. After 12 hours, you are going to give 6 mg again. After 12 hours, you are going to give 6 mg again. Okay, so you are giving 4 injections 12 hours apart, each are 6 mg. That's why corticosteroid has to be given. That is very, very important. Next, we are going to give tocolytics or not. Please remember that if it is less than 34 weeks, there is a saying, if it is less than 34 weeks, guys, I have to give tocolytics. Why? See, tocolytics are basically uterine relaxant. Why I am giving uterine relaxant? Yes, because to prevent preterm labor. If less than 34 weeks may I get uterine contraction in my patient who is a mother who is going to deliver baby. Also, supposing that female also have history of preterm labor, so there is also high risk of getting preterm labor. Okay, so I have to manage it by giving tocolytics, uterine relaxant. So to prevent the preterm labor, I have to give, na? Because if there is premature uterine contraction is there, it is a predictor of abruptio. That means it can develop abruption. Also, it might lead to preterm labor. For that, tocolytics has to be given. But in case of abruption, there is no guideline saying the uses of tocolytics, so we are not going to give any tocolytics here. Okay, another very important thing I would like to mention regarding the anti-D. See, here I told you a very important predictor is trauma. If there is any abdominal trauma is there, I have to give. I have to take a stand here to give anti-D antibodies. Why? See, supposing that is a condition, generally what we do, generally if it is less than 12 weeks, okay, we give 50 microgram anti-D. All I am talking about Rh negative mother. We are not giving anti-D to Rh positive mother. Okay, but if it is more than equals to 12 weeks in Rh negative pregnancy, we are going to give 300 microgram anti-D. But there are two exceptions here. I already explained that even though there is less than 12 weeks, we are not going to give 50 microgram. One is threatened abortion, another is inevitable abortion. Okay, so these are the two abortion where we are not giving 50 microgram anti-D, or we are not giving any anti-D if it is less than 12 weeks. Okay, but if they are more than equals to 12 weeks, we are going to give 300 microgram. That is separate thing. Just I am mentioning as a correlation here. But please remember here, if this is a case of abruptio placenta, or there is a history of abruption, then you have to do a very important test to assess it, that is known as Klehoff-Betke test. So you do this Klehoff-Betke test, and this test, by that you will assess the dose of anti-D that is required. You have to assess the dose of anti-D that is required. Okay, you just cannot give 300 microgram here. Okay, as it is less than 34 means more than equals to 12 weeks, so just giving 300 microgram will not suffice. So you have to assess the dose by Klehoff-Betke test. If there is trauma, then only you are going to do that. Another thing very important is I have to assess the fetus also. Okay, because there is fetal blood loss, so doing weekly NST, and you have to do biophysical score. Okay, you have to do regular Doppler study to look for the fetal status. Now if each and everything is okay here, then only I am going to do induction of labor. Then I am only going to do induction of labor, and I will be going to terminate the pregnancy at 37 to 38 weeks. But supposing that in this expectant management, in this time while I am doing this expectant management, if there is any kind of recurrent bleeding happening, or any kind of fetal distress happening, or any kind of situation which might lead to fetal distress like oligohydramnios, etc., then I have to deliver it as soon as possible. Understood? I think this is very much clear, because expectant management is an update here. Now if it is more than equals to 34 week and mild blood loss is there, fetus is normal, then I can go for immediate vaginal delivery. Okay, so I think this is clear. Now there is something which needs a special mention. Supposing in the assessment I found that there is fetal death, already the fetus is dead. So in that case, the management simply lies on the status of the mother. If the mother is unstable or mother have DIC, mother is unstable or mother got DIC also, in that case, as I told you, emergency management or emergency C-section has to be done. Okay, see, emergency C-section has to be done. But if the mother is stable and you see there is no DIC also, so vaginal delivery can be tried. Now my question is here, please remember, not every case of emergency C-section or any C-section per se, we are doing it by spinal anesthesia na? So neuroaxial blockade is given in C-section, but the catch is if the mother is having DIC. If the mother is having DIC, please remember, first you have to correct the DIC. You correct the DIC, then you are going to go for emergency LSCS under, very important, general anesthesia. So you are going to deliver it under general anesthesia. Normally we do neuroaxial blockade, we give spinal anesthesia there, but in case of DIC we have to correct the DIC first and then I have to go for emergency LSCS under general anesthesia. So hope placental abruption is clear, the management is clear. Thanking you, we'll be meeting again.